Dunnenberger. Mark, I think he's coming to the podium. And he got his degree from the University of Tennessee Health Science Center, College of Pharmacy, 2012, and become the director of Pharmacogenomics in Neamann Center for Personalized Medicine at the NorthShore, I think in the title here. And Mar is really the expert in the pharmacogenomic, especially try to teach bridging between the patient and clinician, and try to developing the information technology to show this gap. And I think he really provides a great education healthcare professional about the pharmacogenomic. Let's welcome Mark.
Okay. Thank you for the introduction. Peter, thanks for the invitation to present. It's been a pleasure working with you over the last 2 years, trying to figure out how we can bring pharmacogenomics to Taiwan and how we can benefit Taiwanese patients with this new data that we have. The presentation I'm going to go over today is not focused on how do you generate the genomic data, but instead focused on, once you have it, how do you turn it into something that's useful and something that will impact the patient's care? We're going to walk through some key learnings that we've picked up from NorthShore HealthSystem, where I work, and how we're applying those here in Taiwan. So this is a picture from the 2001 New Yorker, and this is how they thought that patients might bring their genomic data to a pharmacist to implement pharmacogenomics. I can promise you this is not the solution that we will be doing. I would love that this to be the solution that we'd be doing, because it'd be really easy if all you had to do was bring a piece of paper and we were done. But the reality is, if we were to look at your genome, you would need a lot more than one sheet of paper to get it done. So what does this actually look like in clinical practice if this isn't what we're going to be doing? Well, today, when you go to your physician, they're trying to group you, and they're going to group you with people who have similar features that you do, and they're going to do some differential calculus about telling you that's what they're doing. They're going to say, based on your symptoms, here's the most common thing that's wrong with you, and here's the most likely medication to solve that problem or treatment. It doesn't have to be medication. But it's all about probabilities and using the data they have at hand. And so they see you as a larger group of people, everybody in blue. These can be females in their mid-50s who have high cholesterol, and we want to bring that number down. So what do? We give them all a medication. We think this medication is going to work for most of them, and in fact it does. They're represented in the green here. Their LDL comes down, they don't have any toxicity, they're able to pick up their medication, they actually take it, and everything is good, and they come back to their doctor in 6 months, and it's all smiles and high fives. We also have a group here in the gray, and these are patients who have no therapeutic benefit. So they take the pill every day, cholesterol doesn't go down. Their physician is immediately talking to them about, are you sure you're taking the pill every day? What else are you doing? Why are you not following the diet that I recommended? But there may be some other reasons why those patients aren't responding, but we won't know that until we give them the drug as we practice medicine today. We have patients in the red here, and those are the ones that have adverse event or toxicity. And if we're thinking about statins, this might most notably be muscle pain. And it's kind of a nagging muscle pain that makes it feel like you worked out really hard the night before. You wake up in the morning and now you don't want to walk around. Well, if this is treating cholesterol, one of the things I'm going to tell you to do is to exercise more. So here we have an example of a medication making it harder to do the other thing that I recommended you to do, because you're not going to want to work out if your calf muscle already hurts. Right? When you wake up in the morning and your calf hurts, you're not going to go out for that run that your doctor told you to do. So for these patients, their medications aren't going to work. It could be because they're not able to do their other prescribed treatments, or it could be that if you figure out this pill that I take every day makes my leg hurt, you're probably going to stop taking it, right? So it could be that the patients are not adherent. I gave this presentation one time and somebody pointed out to me there's actually a fourth group of people. and that is the gray plus the red. I'm not sure what color that makes, but these are people who get no benefit and have toxicity. So they get the worst of both worlds. And you really don't want to be a part of that group, but they do exist. So this is how we practice medicine today. We don't know where you're going to be unless we give you the medication, but probabilities suggest that you're going to be in the green unless you're unlucky. So let's imagine a world where we use some test, and in this case, genetics, before we give you the medication. This would be preemptive pharmacogenomics. And now that group of blue people look a lot different. And we're beginning to identify patients who are likely to respond to the medication, as well as those who are likely not to respond and or have side effects. And with that information, what are you going to do? If before you took a medication, you knew it was likely to cause a side effect for you, what would you want your doctor to do? Well, they're going to give you an alternative therapy. It could be they're going to go up on the dose, go down on the dose, or choose a different medication altogether. We live in a world today where in a number of cases we actually have this opportunity. If we're treating those patients with cholesterol, we have about 7 or 8 different statins that are all equally potent or effective to treat patients, and you can pick between them, and the genetic problems don't exist for each one of those. And still, in the world that we live in, most patients are receiving standard of therapy because they don't have the genetic problem for that particular medication. So this is the world we want to operate in, because we can do something about the genetic information before we get it. Unfortunately, as we sit here today, who has their pharmacogenomics profile in the audience? Raise your hand. So I have mine. I've done it 5 times. You know what's cool about doing it 5 times? Because it's the DNA that I got from my mom and my dad, and it's been there since I was born, and it's going to be there till I die. I've done it 5 times, and I got the same answer every single time. So probably a waste of resources, but it highlights something really important. This is something where we can do a test once, and that test has lifetime value for that patient. So as we think about the value of this particular test, you have to think about all of the instances that a patient might be exposed to one of these high-risk medications throughout their lifetime. It's not something that I do it today, I'm going to use it tomorrow, and a week later I don't have to worry about this result anymore. It's a really interesting laboratory finding that we have to deal with. So when we do this, we're going to help clinicians choose between therapeutic alternatives. I told you there were about 9 statins. If we're thinking about depression, there are 15 agents that I could use first line. We've got to pick one of those, so we're helping clinicians pick between therapeutic alternatives, think about problems that they're already dealing with, give them more information, and deliver more effective and safer therapy for the patients. Patients are going to be more likely to take their medication if it's not causing side effects, or if they're getting positive feedback from their clinician that the drug is working. That will decrease hospitalizations, and at the end of the day, you're going to decrease healthcare costs, maybe for that individual, but more probably for the population as a whole, which makes Taiwan a very attractive place to try to get this done because of the national health insurance. Just as a disclaimer, I'm not up here telling you that genetics is the only reason that you're going to respond to a medication. There are a number of other things that are going to come into play. We have environment, behaviors, there are going to be other clinical features that might make me choose one medication over another. But if I can integrate genomics in the right place in your thought process of your clinician, we'll optimize the value of that data and make smarter, more informed decisions for our patients. So I gave you a really abstract idea of how you would use this. This is a case that I'm going to share from my clinic to really drive home the points of why we should use pharmacogenomics and where are the value points for it. So this was a 13-year-old female. She came in with her mom, and they described the daughter having depression over the last 18 months. Every medication they had tried hadn't helped her at all. In fact, she was becoming worse, more withdrawn from school. The mom referred to the drugs that she was taking as the poison she gives her daughter every night before she goes to bed. They also had a brother in this case, and you can imagine if there's a lot of tension between the mom and the sister that it begins to affect the rest of the family, so it was affecting the brother as well, and the husband as reported by the mother. So when we start to think about how we take care of a patient, we have to think about how we take care of the complete family, and improving one person's care actually may help everybody in that social situation. We can't lose sight of that. So these are the 5 medications that she had tried over the last 18 months. I represented here red X's, basically either the drug wasn't working for the depression or it was causing such severe side effects you had to stop it. The yellow X's, we couldn't really tell there was a difference going on. And the green check was that top medication that wasn't working for her depression. Good news is it wasn't causing side effects. So she would be in the red group from earlier, or I guess the gray group from earlier, and everybody below that would be from the red group. These are all very common medications that we give patients for depression. We did a multi-gene panel on this 13-year-old girl, as we do with all patients at NorthShore. And what this allows us to do is, even if you're coming in reactively, so this is somebody who failed antidepressant therapy, so we're reacting to that, doing testing, we're actually gaining data that is prospective in nature. So we have SLC1B1, this is a cholesterol-lowering variant. So in 40 years, if we're still using statins and she needed simvastatin, we'd actually tell them to use an alternative because she would be at greater risk for that muscle pain. So we have this data that we've got to store for about 30 to 40 years and then remind the clinician they did the testing and pull it up and present it to them in a way in which is really useful. So a fun challenge to have. For the depression, there's really 3 variants that we care about here. We take the scientific value represented here and turn it into something a little more meaningful. 2D64 metabolizer, 2C19 intermediate metabolizer, and SLC6A4 poor responder. Don't worry about what the genes mean, but this is kind of that process of taking a laboratory result and starting to turn it into something that's a little more meaningful, right? We can have an idea of what a poor metabolizer might be. But more importantly, when this comes to her case, what did we learn? Well, every medication that we tried, there was a genetic reason for that not to be the best drug to choose for her. And sometimes it matched up pretty well, so venlafaxine was likely to cause side effects, and it did cause side effects for her. Pharmacogenomics is not a crystal ball. It's not going to tell you the one drug that's right for the patient. It's going to help eliminate some options. And so when we looked at her, we still had 3 options that we wanted to recommend for the clinician: venlafaxine, duloxetine, and bupropion. We gave those to the clinician, let them still practice with autonomy. Don't tell them exactly what to do. Give them some freedom to practice medicine. We found that this really helps with uptake. And when we did, the doctor tried bupropion with risperidone for a month, and the patient failed. So we didn't get it right the first time, but it was one of the ones we recommended. And now she's been stable on duloxetine and lurasidone. This slide's old. This is actually about 36 months now that she's been stable on that particular combinations. When we went back and asked the clinician, why did you try bupropion first? It gets back to behaviors. So bupropion was a lot cheaper on this patient's insurance than duloxetine was, which was brand name at the time. And so they wanted to pick a medication the patient could afford and would actually pick up and take. Because if I recommend a medication and a patient doesn't take it, I don't care what your genetics are, it's not going to work for you. It's one of the few things that any doctor will agree. You don't take a medication, it can't hurt you, but it also can't help you. So that's the case for how we did it. And what were the steps that we went through to get it done? Well, you have to obtain genetic data, you have to interpret it, and you have to return it back to the clinician. We're going to skip over the obtaining genomic data for this presentation for the sake of time, and we're going to focus on interpreting the data. So this is what it looks like when it comes off the machine. Everything you need to know about 2D6 for this patient. You can make the right decision if you know what you're looking at. Most of you have puzzled looks on your faces, very similar to clinicians that I would give this to. Instead, we have to turn it into something that's a little more meaningful. So this is 2 sentences, probably still too long for your average clinician. They don't have enough time to read 2 sentences, but you know exactly what to do. Choose an alternative therapy when starting depression for this patient. And there's actually a group out there that helps us make those recommendations. This group is called CPIC, or the Clinical Pharmacogenomics Implementation Consortium, and they write guidelines on what to do with the genomic information if you have it. They're not tackling the problem of, here's when you should get it, but instead, if you have it, here's how you maximize its value. And it's an international group, and we've been writing guidelines since the early 2008, 2009 time period. But the idea here was, if we tell you how to use the data, clinicians will figure out when they should use it in their practice. And we're starting to see that across the United States as well as other parts of the world. And their whole guideline is based on this process of translating the data, taking a genotype, turning it into a diplotype, and then turning that into a phenotype, making it a little more useful, and then really bringing it into a therapeutic recommendation. This idea, this flow, is very similar to how clinicians have been using other laboratory values in the past. So you can think about a serum creatinine, that's the equivalent of a genotype or a diplotype, a laboratory value. You do a calculation on it, in this case it's phenotype, and the serum creatinine is creatinine clearance. And once you have that, then you can use it to make a therapeutic recommendation. For creatinine clearance, it may be space out the antibiotic to every 48 hours instead of every 24. So very similar to what clinicians were already doing, just applying it with a new data set. So as you think about returning genomic data, pharmacogenomics is very different than all the other genetics we talked about today, in the fact that everybody has some pharmacogenomic variant. So this is on a 7-gene panel. 98% of patients at NorthShore had a pharmacogenomic variant. And in fact, most patients had multiple pharmacogenomic variants. So this is multiple opportunities to make a difference. We replicated, this data was also replicated at Vanderbilt, in the VA, and a number of other places. And looking at the Taiwanese data, it looks like it will replicate here as well. We'll share some of that in a minute. What's unique about Asian versus Caucasian data is it's not the fact that variants exist or do not exist, it's the genes in which they exist. So here we have CYP2C19, which is more problematic in an Asian population than it is in the Caucasian population. But for 2C9, you actually see that more patients are average than compared to a Caucasian population. So we're not exactly sure which variants are going to be here when we start testing people, but we know they're going to be here, and they're going to be problems that we're going to have to tackle, and opportunities to improve patient care and drug usage using pharmacogenomic data. So I'm going to share a little bit about what pharmacogenomics we look at NorthShore and how we're trying to do that here in Taiwan. So it's been a journey over the last 5 years at NorthShore. We started out really small, picking things that we had the resources to do. So we looked at clinical areas where we were already using genomics into practice and figured out how we could optimize that. And then we started to create a safety net, and that safety net was with a dedicated pharmacogenomics clinic. So if you were a patient and wanted to use it, you could come to our clinic and we could talk you through that process. If you were a clinician and wanted to use it, you could send a patient to our clinic and we could talk you through that process. Once we began to understand how people were utilizing pharmacogenomics and what they wanted to do with it, we were then able to build bigger support to go across the healthcare system. And just in April, we went live with a program called DNA 10K, where we're testing people for a whole bunch of other reasons, but we're doing it on a genome backbone. And now we're extracting the pharmacogenomic relevant data from that backbone and delivering that to the patients and improving their care. So these patients are getting pharmacogenomic data, but their testing was done for another reason. And so this is basically, you get to have something for free when you get a different tests on top of it. And this represents what we think might be a good way to bring pharmacogenomics to a population. So to get all of this done, there's basically 5 components that you have to do. You have to do genetic testing. We'll talk about that here. You also have to do education. We've been doing that here in Taiwan through the flagship program. And in April, I was here giving a seminar, a whole day-long seminar, 8 hours of having to listen to me talk. You can moan and groan because it wasn't that enjoyable, I'm sure. But we really talked about how you would use pharmacogenomics, break it down, make sense to the average pharmacist here in Taiwan. And it was a wonderful event that I enjoyed being a part of. And in the middle here, we have things in blue. These are HIT-related things. So you have to have a genetic variant result database, or you have to know what variants you're going to find, and you have to be able to track them. So we've been doing some work here in Taiwan with identifying which are the most common variants that are actionable or known to be actionable, which ones are found here, so we can build a test off of that. So Cheryl's been doing a lot of work there. We're also working on a knowledge base or a clinical decision support knowledge base where, all right, we know what CPIC does. How does that translate into Mandarin? And how does that translate to practice here? What do Taiwanese clinicians want to see? What do Taiwanese pharmacists and patients want to see that might be different than what's true in the United States? So we're working on that, as well as where is the data available to say that this genetic variant is actually different and acts different in an Asian population compared to a Caucasian population? A number of the resources out there today are wholly focused on Caucasians, and there's data to suggest in some settings the genetic variant may act different in Asians. So can we build that support here? We're working on that as well. And then the toughest challenge that we're going to have is how do you deliver that into the healthcare system here? Who's going to be the utilizer of the data? And that's the bigger problem, the bigger challenge that we haven't started tackling it yet, but something I look forward to working on in the next 6 to 8 months. I just want to thank the people at NorthShore that I work with. So this is the team that runs this particular program. You may recognize some of the names, but you might not. And what might be more important to you is what are their specialties. And what you see is that pharmacogenomics is a collaborative, multidisciplinary team to get it done. You're not just going to have one person go out, start a program, and run it and implement it successfully in any setting. You really need to buy across the care spectrum, and we've been able to do that successfully with NorthShore and trying to replicate that here in Taiwan. And I'm going to close with talking about the value of pharmacogenomics. So I just showed you that you can do it. Now the question is, why do you want to do it? And we've begun to look at some of this at NorthShore as well as other institutions. I'll share NorthShore data. So we asked some clinicians who have been practicing with pharmacogenomics, they'd all been exposed to it. Why are you ordering it? Why are you utilizing it? What are your challenges that you have? And so they think it will help them aid in individualizing treatments. Our case kind of represents that. One of the things that was really interesting is it's aiding in their ability to have mutual shared decision making. So this is engaging the patient in their own care process. And we know that that helps patients have better outcomes with their care process if they believe they had some stake in the game. And then there's this other aspect coming up that it's increasing patient satisfaction, and it's also changing some psychosocial aspects of the patient's life, meaning I'm going to be more likely to take this medication because I believe it's going to work because my doctor had more information to make the decision that this was the right one for me. So this was coming across from a provider point of view. We thought that was pretty interesting that they were picking up on that. I'm going to show you in a second some other data that also agrees with that. Challenges, it's complicated to communicate pharmacogenomic results, it's time consuming, and it does cost money to do pharmacogenomics. These challenges, I'm pretty sure if I took out PGX and put something else, communicating results as a challenge, time and money, it would be any problem that you've dealt with in healthcare, those challenges still exist. It's hard to do healthcare. We're not going to solve that with pharmacogenomics. So after we did the provider survey, we then went in and asked some patients who had done pharmacogenomics, why were you using it? What did you find was valuable? And I just want to highlight two examples here, or two questions. So we asked them, I feel more confident in medications prescribed to me, that they won't cause side effects, likely to help my condition compared to drugs in the past. On a Likert scale, over 70% of the people agreed with that statement or strongly agreed with it. So that idea that clinicians were picking up on, here we have patients telling us the exact same thing, and that's cool, but if you don't take that and then do something with it, it doesn't matter that much. And so we followed it up by asking them, are you more likely to take your medications? And over 50% of the population said, yes, they're more likely to take their medications because they had pharmacogenomics available during their care. This wasn't people who had changes made because of their pharmacogenomics. It was just because that data was available to the patient and the provider at the time of prescribing. So I will go ahead and own up that these were survey data. It doesn't tell me what happened in the real world, but we're beginning to get a signal that there is something more here than just picking the right medication for the patient. There's some psychological activation going on, and we need to do more studies for that. So just to wrap up, when I think about the flagship collaboration and what we've been able to do and what we're trying to do, it's really three particular things. So we're trying to determine the pharmacogenomic variants that are important in the Taiwanese population. Because if we do that, we can do a test. We're trying to build infrastructure to support the needs so that we can actually deliver this to care. And then finally, we're going to try to capitalize on unique Taiwanese resources to further explore the value of doing implementation. And you guys are uniquely suited here to be able to get that done, and that's what's really exciting to me as we move forward. I will leave this slide up, but I will take some questions if we have time.